We pray, King of Glory, that you endow us with the knowledge so that whatever it is that we do in our clinical practice may bring glory and honor unto your name. Even this morning, Father God, I pray that you give us the understanding, give us the wisdom to decipher everything that we are going to study. And Father God, even as I'm going to lead this and moderate this session, I pray that you be honored, not I, but Christ, loved and exalted. Not I, but Christ be seen, be known, and be heard. Not I, but Christ in every look and in every action. Not I, but Christ in every thought and in every word. In Jesus' name, I pray, trusting and believing. Amen. Okay, so do we give our latecomers a moment or two ama tuendelee tu? Okay, mmoja nitumie maswali, mmoja ni endelee na score sheet. I hope it's being recorded. I hope it's being recorded. Uh, 6:39, Sharon. Because we're doing, I was made to understand we are doing paper 1 KRCHN. We are doing a continuation from question 356. Happiness naye aliamua kutoa ile bench ya backbenchers wenye wanakalianga, wale wenye wasemangi anything kwa group. Going forward lazima itabidi wamesimama. Wanakaa comfortably, making the group vibrant, not making the group vibrant. People will kill me. All right, I'm ready when you're ready with the next question, 356. Oh no, oh no, oh no. Forgot to connect to Wi-Fi. Just a minute. Okay. Can I be heard now? If so, we can pick it up from there. Three 56. 356 or 365? 356, okay. So 356, the main cause of diabetic ketoacidosis. The main cause of diabetic ketoacidosis are A, infection, physical trauma, self-medication. B, decreased dose of insulin and illness, missed dose of insulin. C, sepsis, renal disease, liver failure. D, increased dose of insulin, starvation, use of expired insulin. So what would cause DKA? Infection, physical trauma, self-medication. B, decreased dose of insulin, an illness, missed dose of insulin. C, sepsis, renal disease, liver failure. D, decreased dose of insulin, starvation, use of expired insulin. Shall we? You can see B. Dorcas goes with B. B. Good trial. Yeah, so we must understand that decreased dose of insulin, presence of an illness, and missed dose of insulin are reasons as to why you can end up with diabetic ketoacidosis. You see, DKA is a life-threatening problem. It happens when your body does not have enough insulin to use sugar for energy. So without insulin, your body will end up breaking down fats too fast. And this creates acids that are called ketones. And these ketones make your blood too acidic, okay? So when you miss a dose of insulin or there's decrease in the dose, if you forget a shot or take too little, your insulin levels drop too low. Now, illnesses work in such a way that when you're sick, your body makes stress hormones. These stress hormones fight the effect of insulin. This causes your blood sugar to go up. When you get sick, your body treats the infection like an emergency. I want you to understand the concept behind illnesses leading to DKA, because the brain triggers the fight or flight response, pumping out stress hormones like adrenaline and cortisol, these catecholamines. Now, these hormones, when they're released, they will give you quick energy, but they also turn off your normal immune response work, you see? So that over time, too much of the hormones make your body weak. So these stress hormones like adrenaline, especially adrenaline, this hormone acts like a gas pedal, if I would use such an analogy. It makes your heart beat very fast. It opens your airways so that you can breathe deeply during a crisis. And then there's that cortisol that is also produced when you have DKA in illnesses. And that hormone in the body is an alarm system. It raises your blood sugar, it gives you energy. It also turns off non-essential functions to focus on the disease process. Now, the immune system, when the immune system is hit, cortisol tells the immune system to stop working temporarily to save energy. Think of it like a business closing a store to save on electricity. I don't know if you get the analogy. A business closing a store to save on electricity. You might feel a quick burst of energy, but you cannot heal as fast. That is how the cortisol works when you're sick in diabetic cases. More inflammation when the stress is constant, the body stops listening to the stop signals from cortisol. This causes long-term inflammation that makes you feel achy, tired, and more likely to catch even a cold. So slow recovery, if you're always stressed, your body stays stuck in the high alert mode. This takes time and energy away from fixing your illness. So the analogy that we used to be given when we were back in campus was that imagine your body is a house. If there's a break-in, an illness, that is, you set off the alarm, which is the stress hormones, cortisol and adrenaline. The alarm is loud and grabs all your attention. But while the alarm is ringing, no one is in the kitchen cooking dinner or washing dishes. If the alarm rings too long, then the house falls into a messy start, you see? So that is how DKA is manifested during disease processes. Now, some of the warning signs of DKA are normally occur quickly, mostly in 24 hours. So you keep an eye out for high blood sugar, hyperglycemia, high ketone levels in urine, extreme thirst, polydipsia, polyuria, frequent urination, nausea and vomiting, abdominal pain, shortness of breath, fruity scented breath, confusion and fatigue. And under such circumstances, you have to receive emergency medical treatment. So you need fluid replacement. Intravenous fluids replace the lost liquids and dilute excess sugar that is in the system. You need insulin therapy that lowers the blood sugar and stops ketone production. You need electrolyte replacement. Minerals like potassium are given to keep the heart and muscles working safely. So when you are at home, you make sure you prevent it by monitoring your blood sugar levels regularly. You test for ketones using urine strips. And if your blood sugar passes 13.3 millimoles per liter or 240 milligrams per deciliter, then you know you are about to catch DKA. And also adjust insulin doses when you are at home. Work with your medical practitioner. Create a sick day plan for when you are ill. Take your medications timely. Never keep insulin doses without medical guidance, because DKA is very fatal. Okay, so we can continue to 357. I saw something sent here by Cindy. DKA, deadly delirium, dehydration, aching muscles, abdominal pain, cosmal breathing, precipitating factors, new onset IIDM, major illness, infection, cerebrovascular events, myocardial infarction, glucocorticoids, missing insulin doses. So IV fluids, as we've said, you correct electrolyte imbalances, and then you take your glucose. So never take DKA easily. It can finish you in no time. Can I get CTs as we continue? Ule shetani wa pornographic material pia ashindwe, unless there are people who are enjoying. You never know. This is a society. Somebody is just hoping itatumu. 357. 357, guys. You know, I have the questions. So it's you who needs the questions. Mimi nilidownload usiku. Or insulin ranges when you want to know that if it goes below 13.3 millimoles per liter or below 240 milligrams per deciliter, then you know DKA is about to check in. So question 357, the following is true regarding Hashimoto's thyroiditis. It's an autoimmune disease caused by primary hypothyroidism. It's an autoimmune disease caused by primary hyperthyroidism, results in goiter, causes exophthalmos. More common in women, there is an increase in thyroxine hormone levels, thyroid hormone levels. So what is true regarding Hashimoto's disease? Let us give it a try. Can see most of us going with A. Yeah, so Hashimoto's disease is an autoimmune disease, and it is primarily caused by hypothyroidism. In Hashimoto's disease, you see the body's immune system mistakenly attacks the thyroid gland. That is the autoimmune part of it. Now, primary hypothyroidism is when it damages the thyroid directly, making it unable to produce enough thyroid hormone. And when you lack thyroid hormone, the pituitary gland tends to release extra thyroid stimulating hormone, signaling primary hypothyroidism. Now, with this Hashimoto's disease, thyroiditis, in its chronic autoimmunity, the immune system attracts the thyroid gland, often leading to hypothyroidism, underactive thyroid. So it is highly treatable using a daily replacement hormone medication, which is called levothyroxine, and ongoing blood monitoring to restore and maintain normal thyroid hormone levels. So normally it's caused by genetic factors. It is a familial thing, the autoimmunity. It is more common in women than in men, and it attacks people mainly at ages 30 and 60. So if you're 30, start caring for your thyroid gland. So diagnosis is made primarily by endocrinology, using blood tests to evaluate the levels of thyroid function. So thyroid stimulating hormone test is often elevated, indicating that the pituitary gland is overworking to stimulate the failing thyroid. And then there's also the T4 test that often shows low levels of primary thyroid hormone. And there's also thyroid antibody test, TAT. It detects the presence of TPO, which is thyroid peroxidase antibodies, confirming that the autoimmune nature of the disease. So we know that it is easily managed by medication levothyroxine, and you definitely need to be monitoring. You need to be monitoring your blood tests. And you also have to make sure that a lifestyle is maintained whereby a balanced diet and stress reduction is managed, okay? So for option B, it's incorrect because Hashimoto's ultimately causes underactive glands, hypothyroidism. For option C, I want you to get back to that question. Option C is incorrect because exophthalmos, this bulging eyes, is caused by Graves' disease, not Hashimoto's disease. And in D, thyroid hormone levels decrease in hypothyroidism, not increase, okay? So make sure you understand also the signs and symptoms of hypothyroidism. Things like extreme fatigue, weight gain, and profound intolerance to cold. They feel cold easily. And their skin becomes very dry and coarse and thin and brittle hair. They constantly constipate due to slowed intestinal motility. They have slowed heart rate or bradycardia. And they become psychiatric because in most cases they get depressed and they have memory problems, what we call memory fog. And they end up with slowed speech over time, okay? In women, the reproductive system becomes the menstrual system becomes irregular in women. So that is why they are given this levothyroxine, because this levothyroxine is synthetic T4 replacement. So it is endogenous, and the thyroid, it is an endogenous type of thyroid hormone. It replaces the exact hormone that damaged thyroid gland can no longer produce. So at a peripheral conversion, once absorbed into the bloodstream, tissues, primarily the liver and the kidneys, remove the iodine atom to convert levothyroxine into triiodothyroxine, T3. So we know that loop system whereby T4 gets to the liver and kidneys and is converted to T3, and then nuclear receptor binding, the T3 enters the cell nuclei and binds to specific thyroid hormone receptors. And this action triggers gene transcription to normalize metabolism, protein synthesis, cardiac function, you see? And yeah, exactly. Everything is low and slow. So the negative feedback loop acts in such a way that T4 and T3 satisfy the pituitary gland, and this causes it to decrease the overproduction of thyroid stimulating hormone, back to normal ranges. So your only means of making it is by levothyroxine being administered, which is always quite expensive. Sharon sent something here on thyroiditis. Can be acute, subacute, or chronic. Each type is characterized by inflammation, fibrosis, or lymphocytic infiltration of the thyroid gland. Acute thyroiditis is rare, caused by infection of the thyroid gland, autoimmune infection. The causes can also be bacteria like Staphylococcus aureus, which is most common, fungi, mycobacteria, or parasites. What we are trying to discuss here? Okay, anyway, subacute cases may be granulomatous thyroiditis, dequivariance thyroiditis, or painless thyroiditis, silent thyroiditis, or subacute lymphocytic thyroiditis. This form often occurs in the postpartum period and is thought to be an autoimmune reaction. Yeah. So read through the clinical manifestations, like I just said, and the management. If it's caused by bacteria, then you can also get into antimicrobial agents, and surgical incision and drainage is if the abscess is present. So take NSAIDs, take corticosteroids. Painless thyroiditis can be treated with treatment is direct at symptomatic, but look into Hashimoto's disease at a personal level, and make sure that you learn more about Hashimoto's disease, just for the sake of your clinical practice and for the exam. Can I get your CTs? But exactly remember how this levothyroxine works. Yeah, cut a score sheet. Mimi kazi yangu tu ni moderate. You see, make sure you understand how this levothyroxine works, because it's just remember 4 things: synthetic T4 replacement, peripheral conversion of T4 to T3, and the nuclear receptor binding. That is, the converted T3 enters the cell's nuclei and binds to specific thyroid hormone receptors. And then after that, there's a negative loop feedback whereby now this causes the overproduction of TSH, and the body goes back to normal. For those who will be doing NCLEX later on after this, you'll find such questions and it will be good for you. Question 358, that says, all of the following nursing diagnoses are appropriate for a client with acute asthmatic attack. Which is the highest priority? What is the highest nursing diagnosis priority when somebody is having an asthmatic attack, acute one? Anxiety related to difficulty in breathing. B, ineffective airway clearance related to bronchoconstriction and increased mucus production. C, ineffective breathing pattern related to discomfort during breathing. D, ineffective health maintenance related to lack of knowledge about attack triggers and appropriate use of medication. Good nurses, tuanguke na hiyo. Yes, I can see most of us going with B. B says that the correct nursing diagnosis should be ineffective airway clearance related to bronchoconstriction and increased mucus production. So in nursing care, prioritization is guided by the Maslow's hierarchy of needs, where airway, breathing, circulation framework is employed, okay? Now, I'm only whenever I'm revising for these questions, I always try to look at all the other choices that were also given to see what the examiner was trying to think. I don't know if it's always okay with you, but if it's okay, fine. If it's not, then I would leave it at that. But you should understand that when somebody is having an asthmatic attack, the immediate nursing intervention should be to elevate the head, sit the client upright in a high phallus position or a forward-leaning tripod position to maximize chest expansion. And then you also give oxygen, high flow supplemental oxygen at 94% immediately. And then learn to stay calm. Remain with the client to reduce psychological distress and severe panic, because that would worsen hyperventilation and bronchospasms. And then you keep track of the vital signs, because you have to track the respiratory rate, the heart rate, the pulse, oximetry continuously, while auscultating the lung sounds for wheezing or silent chest. Because you can be oxygenating somebody who is already dead, you see. You secure intravenous accesses promptly for emergency fluid delivery and administration of systemic medications. So in as much as you are taking care of prioritizing the ABCs, you must also consider these other means of interventions. And in that process too, also make sure that first-line emergency medications are available. The SABAs, that is short-acting beta-2 agonists like albuterol, administered via a nebulizer immediately to rapidly relax the smooth muscles and dilate the bronchioles. You also have to have anticholinergics, because you combine ipraproteam bromide with albuterol, these short-acting beta agonists, to provide synergistic bronchodilation and reduce excessive mucus production. And then you also have to give systemic corticosteroids like prednisone or methylprednisolone. In Mater Hospital, I saw they only give methylprednisolone. They said prednisone is for easy hospitaliza chini chini. So you give intravenous or oral methylprednisolone or prednisone early to reduce severe airway inflammation and prevent late phase relapse. You also give magnesium sulfate. Why do you give magnesium sulfate? Because this is a patient who has already had muscle twitching. So the magnesium sulfate is given as an adjunct therapy in severe cases to induce rapid smooth muscle relaxation so that the breathing system can be restored. Okay. Now, why was answer A incorrect? Anxiety is a psychological problem and more of an emotional response. So while severe distress can worsen an attack, it falls lower on the physiological priority scale compared to structural airway problems that we are trying to handle in this patient who has an asthmatic attack. And for C, an ineffective breathing pattern addresses the mechanisms. This is more of mechanisms and rhythms of respiration, such as hyperventilating. Though it's highly critical, it is secondary to resolving the mechanical airway clearance blockages that were preventing the airflow or the patient getting air into the lungs. For D, ineffective health maintenance is an educational thing and a long-term behavioral diagnosis. This is something that you teach the patient, and they must learn about triggers and medications used in crucial states of asthmatic attacks for discharge planning. And it's a low priority during a life-threatening emergency medical crisis. So remember the medications, remember the interventions as we continue to the next question. Can I get CTs? Epinephrine can also be given, but now the epinephrine has one problem. It will act on other systems too. Just reply a message here. Okay, we're moving to question 360. Russell's traction is indicated in a before I even go, you see, epinephrine can be given in asthmatic attack, but normally it is reserved for severe life-threatening emergencies or cases that are triggered by allergic reactions or anaphylactic cases, but it can be used. So get answered on that. Russell's traction 359 is indicated in A, femur, knee, hip fractures, B, femur, acetabulum, and lower leg fractures, C, minor fractures, lower spine, sciatica, muscle spasms, D, degenerative disc disease of the cervical spine, shoulder dislocation, and muscle spasms. Can we try 359? Can see most of you going with A. Most of you going with A. Yeah, so Russell's traction it's Russell's traction. Hey, Russell's traction also has another name. Yeah. From the person that Hamilton-Russell's traction. Yeah, Hamilton-Russell's traction. It is a form of balanced skin traction that utilizes the system of ropes, a knee sling, and pulleys. And specifically, it's designed to exert a pulling force along the longitudinal axis of the thigh. So it lifts the knee. This double pull mechanism stabilizes injuries, reduces muscle spasms, and it also maintains an alignment of the femur fractures, knee injuries, and hip fractures. Okay. I wish I had pictorials of how they look, but inakaa ni kama kachuma tu kamewekwa ni kama unaivaa kama trouser, the Hamilton Russells. Okay. For option B, acetabular fractures typically require exactly. Thanks, my dear. The acetabular fractures typically require skeletal traction, such as femoral skeletal traction, rather than Russell's skin traction to overcome the heavy muscle pull on the pelvis. For option C, minor fractures of the lower spine, the sciatica, the lumbar muscle spasms are treated using pelvic traction. Okay. Remember, there's Russell's skin traction and there's Russell's traction. So the Russell's skin traction is used for acetabular fractures. Okay. For minor fractures of the lower spine and sciatica and lumbar muscle spasms, you can use a pelvic traction or a pelvic belt, not a Russell's traction. For degenerative disc diseases of the cervical spine and neck spasms, those require cervical traction, such as a halter or a Crutchfield tongs. So ni kitu inakaa kama headphones, inawekwa kwa kichwa, the Crutchfield tongs, so that it decompresses the neck and the vertebrae. Okay. So skin traction, let me just tell you, just for the sake of it, exact gallows, good. Skin traction, skin traction is non-invasive. So the pull is applied directly to the skin using boots, straps, and adhesive sleeves. And its weight, you must also always consider the weight, 2.3, and it must not go beyond 3.5 kilograms to prevent skin breakdown, blistering, or necrosis. And it's only for a short duration, like 48 to 72 hours until surgery is scheduled, like back traction, Russell's traction, Bryant's traction for pediatrics. Remember, Bryant's traction is for pediatrics. That is skin traction, and it's non-invasive. For skeletal traction, which is invasive, the pull is applied directly to the bone using surgically inserted pins, wires, and tongs. So the weight can be 11, but cannot exceed 18 to 20 kilograms, depending on the patient size. And this one is now long-term for bone healing or structural realignment. So we have examples like balance suspension in Thomas splint and that Crutchfield tongs. And there's also Stillman pins. You've seen those people with wamekewa chuma and then pins zinatokea from the outside. Okay. So as a nurse, your work is to never modify weights. The weights must hang freely off the floor. Do not lift or remove the weights unless ordered in an emergency. Your work is also to check the ropes, ensure that those ropes are smoothly in the center of the pulley tracks without fraying or moving up and about. You also have to make sure that the skin and pins are cared for because of infection prevention. You perform pin site care using chlorhexidine or sterile saline to prevent osteomyelitis in the skeletal traction, I mean. Yeah, so I think that is all I know about traction. We can move to question 360, cities. I can see something has been sent here by Hydra. Yeah. But if you ever intend to go and work outside the country, make sure these things ziko tu kwa fingertips. Because those people, they will say you have a problem with the language. Kumbe ni content hauna. Upper extremity, we have sidearm skin or skeletal, forearm, lower extremity, back thruzzles, spinal, we have halters, halo, pelvic belt, pelvic slings. Nice. Thanks, Hydra. Let me get question 360. Characteristics of second-degree burns include waxy, white, dry, leathery, charred, edema, fluid-filled blisters, weeping of fluid, bright pink, red to gray, may have local edema. D, severe pain, weeping of fluid, may have local edema, leathery charred. Yeah, second-degree burns. Guy, it's almost 5:40. Okay, give me your trials. Na usiwahi ogopa kuweka answer. Hata mimi nilikuanga naogopa back in the days. Can see B, Sensha B, Missy, Rambrizo, Foz, Ima, Shaz, Baha, Pam. Interesting, because second-degree burns are fluid-filled blisters, weeping of fluid, and they are bright pink. You see, second-degree burns are also called partial thickness burns. They damage the top two layers of the skin, the epidermis that contains the stratum corneum, stratum lucidium, stratum granulosum, spinosum, and basale, and the dermis. So both epidermis and dermis are affected, and this causes the skin to look bright pink or red, feel moist, and easily form fluid-filled blisters. Okay, so for option A describes a 3rd-degree burn. The skin becomes waxy, white, and dry and charred. That option C is too mild. It describes a 1st-degree burn and a very superficial injury. For option D is a mix-up. While the 2nd-degree burns are very painful and with fluid, a leathery charred look is a sign of a 3rd-degree burn. Okay. For superficial burns and 2nd-degree burns, okay, I think we've seen them while looking at those different choices. So first aid measures is that you cool immediately. Run, cool, not cold, cool. Tap water over the burn for 10 to 20 minutes. You remove the tight items. This is nursing action now. You take off rings, bracelets, or clothing gently before the area swells. You keep the blisters intact. Don't pop the fluid blisters as they protect against infection. Moisturize and cover by applying petroleum jelly or aloe vera. Then cover loosely with a sterile, non-stick bandage. Critical infection warning signs would be increased redness spreading outward from the burnt site. There would be foul-smelling pulse or cloudy fluid oozing from the wound. There would be fever or chills developing unexpectedly or worsening pain and swelling over the days. Okay. I can see we've been sent something here by, yeah, this visual type is making more sense. So 1st-degree, you can see there are no blisters. 2nd-degree, it affects the epidermis and parts of the dermis. 3rd-degree, you can see there is white, brown, or charred leathery skin. 4th-degree, that one now goes beyond. There is charred blackened tissue, life-threatening, and requires emergency treatment. So rule of nines, we are going to come to these rules of nines in a few questions ahead. In the next question, 361. Give me your, something was also sent here by Joy. Burns, locations, and complications. Respiratory issues are at the head, neck, chest, and torso. Compartment syndrome affects the arms and legs. Disability, hands, feet, joints, eyes. Infection, perianal, eyes and ears. Impaired healing, diabetes, CKD, and malnourishing. Types of burns, there are thermal burns, chemical burns, electric burns, radiation, cold, where we have frost bites, and friction. Those can also cause burns. So take your time and look through those evidences, and thank you so much for them. Thank you for your CTs, and give me the next question. When estimating the size of burns, the palm of the patient's hand represents body surface area of 3%, 1%, 4.5%, 9%. Can see B, 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 B. This one really used to give me trouble back in the days. Now, I want you to give me a good listening ear for this. Well, the correct answer is 1%. And healthcare providers, in most cases, they use the rule of palms to estimate the size of small, patchy, or scattered burns. So when the patient's palm and fingers are held tightly together, this surface area equals roughly 1% of their total body surface area. So the rule of palms, the entire hand palm plus fingers equals 1%. Now, there are some medical practitioners who say that you use just the palm, which is about 0.5%, but generally it's always 1%. Now, the patient's hand, always use the patient's hand size and never use your own. Okay? There's also the rule of nines. Use the larger band, used for larger bands. It divides the adult body into main sections of nines or multiples of nines. So 4.5, 9, 18, and such. And then there's the rule of palms, where the entire hand, palm plus fingers, equals 1. So some medical practitioners use just the palm, which is about 0.5%. Now, patient's hands, always use the patient's hand size, not your own hand. Okay? Now, when you are estimating the size of the burns, the total body surface area that has been affected by the burns, for adults, there's the rule of nines. So the head and neck, 9%, because 4.5% front, 4.5% back. The torso or the trunk is 36%, 18% chest and abdomen, 18% upper, lower back. Each arm, 9% total, 4.5% front, 4.5% back. Each leg, 18%, 9% front, 9% back. Perineum or genitals is 1%. That is the rule of nines. There's also the Landbrauder's chart that is used for pediatrics. The Landbrauder's charts for pediatrics is the most accurate calculation method because it accounts for the age and development of the body by adjusting percentages as the person grows. So children versus adults have it that children have proportionally larger heads and smaller legs than adults, you see? And there are dynamic changes, like for an infant, the head accounts for 18% of the total body surface area, while each leg is only about 14%. And as the child grows, the head percentage decreases and the leg percentage increases. So it is preferably used in specialized burn units because precise fluid resuscitation formulas depend heavily on the accurate total body surface area tracking. And then there's the rule of the palms. So as I had mentioned earlier, the rule of the palms. So remember the rule of the nines, the Landbrauder's rule, and the rule of the palms, okay? The accuracy for rule of nines is moderate. The accuracy of Landbrauder's is high, and the rule of palms is also moderate. So remember that. Let's move with cities. Thank you for this, Hydra, for the rule of nines. Try and check for the Landbrauder's rules. Thank you, Samuel. Thank you. Thank you. Give me the next question. In 362, okay, the early signs of cancer of the posterior nasal space include, the early signs of cancer of the posterior nasal space include A, proptosis, hearing loss, B, hearing loss, double vision, C, purulent nasal discharge, aphonia, D, insomnia, proptosis. What are the early signs of cancer of the posterior nasal space? You can see we're going with B. B. Andika tu, this is adult learning, hakuna kuchapwa au kuchekwa. So 362B, yeah, so you'll always have that these patients will have hearing loss and double vision. You see, cancer of the posterior nasal space or nasopharyngeal carcinoma often grows near the eustachian tube and the eye nerves. Now, that is why you also have to be very careful with Burkitt's lymphoma that attacks the face. That one I saw in MTRH, inaitwanga aje, Shoe for Africa. When you have cancer of the posterior nasal space, the nasopharyngeal carcinoma often grows near the eustachian tube and the eye nerves, and it blocks the ear, causing hearing loss, and it also presses on the nerves that control eye movement, so the child will have double vision, okay? Give me CTs. Give me CTs. Aki, I hope mmeelewa. Posterior nasal space, eustachian tube, and eye nerves. So you'll have hearing loss and double vision. Thank you. Next question, baby girl. Someone, I'm saying what I know, you can confirm with an evidence to correct wherever you deem was not making sense. Samuel. So when you get your free time, ingia online. Si mlichokoza Sharon na Nimo na these are the ladies that used to get us Gracie. Saizi sasa mmekaliwa ngumu. Okay, ndio hiyo moja, mtu wangu wa audiovisual learning. So stage 1, a small tumor confined solely to the nasopharynx. There is no spread. Stage 2, the tumor extends nearby tissues, lymph nodes on one side. There is a node that is 6 centimeters. Stage 3, the tumor has spread to the nearby area and or multiply lymph nodes, may involve lymph nodes on both sides of the neck. Stage 4, it has spread to the bones, nearby critical structures like the skull, cranial nerves, large lymph nodes or lymph nodes in the lower neck, distance, metastasizes. Look for a condition called Burkitt's lymphoma. Then you'll really understand this question. So we do 363. A client complains of decreasing peripheral vision halos around lights. These manifestations are characteristics of a retinal detachment, open angle glaucoma, cataract, macular degeneration, vision, peripheral vision, decreasing peripheral vision and halos. Hiyo ni rahisi. I can see D. Macular degeneration, I can see D. Any other? Can see A, D, A, D, A, D, B. This G goes with B, D, B. Okay, now hapa I'm going to be forced to go through all the choices. With the retinal detachment, Retinal detachment is an ophthalmic emergency that is characterized by painless appearance of floaters, flashes of light, or a shadow, like a curtain sort of, falling across the field of vision rather than a slow decline with halos. For B, open-angle glaucoma is often called the silent thief of sight because it progresses slowly and painlessly. The gradual buildup of intraocular pressure would damage the optic nerve, and primarily it destroys the outer edges of the retina first. Now, this results in a gradual progressive loss of peripheral vision, what we call tunnel vision. So as fluid pressure fluctuates or remains elevated, it causes the corneal edema, okay? When we have corneal edema, which refracts light abnormally and causes the patient to see halos around signs. So for those who are going with cataract, this involves the gradual clouding of eyes, especially the lens. Not especially, actually the lens. It leads to overall blurred or dim vision, decreased color perception, severe glare from bright lights, but it reduces both central and peripheral vision uniformly rather than isolating peripheral vision. For macular degeneration, this is a condition that it damages the macula and is responsible for sharp, straight ahead sight. Therefore, it causes loss of central vision, leaving the patient's peripheral vision completely intact, okay? So it is open angle glaucoma, okay? Thank you so much for the evidences. Hydra says cataract, clouding of the lens, blood vision, glare sensitivity, glaucoma, increased intraocular pressure, peripheral vision loss, optic nerve damage, conjunctivitis, red eye, itching and discharge, highly contagious. It's viral and bacterial. Macular degeneration, central vision loss, common in older adults. Diabetic retinopathy, retinal blood vessel damage, diabetes-related vision loss. Retinal detachment, flashes of light, floaters, curtain-like vision loss. Dry eye syndrome, burning sensation, gritty feeling, excessive tearing. Corneal abrasion, eye pain, photophobia, foreign body sensation. Stye hodolium, painful eye lamp, localized infection. NCLEX tips, glaucoma, increased eye pressure. Cataract, cloudy lens. Retinal detachment, emergency. Diabetic retinopathy, not now. Diabetic retinopathy, diabetes complication. Okay. And yeah, Samuel, enyewe unahitaji both. Okay, so can we CTB? Now, remember that nursing intervention in glaucoma intervention, when we are dealing with a patient with glaucoma, medication, administration, and teaching, this is a lifelong therapy. Listen to this, it's a lifelong therapy. So you teach the client that glaucoma medications must be used for life, even if they have no symptoms. And then there's something called punctal occlusion. So you instruct your client to press on the inner corner of the eye for 1 to 2 minutes after administering eye drops to prevent systemic absorption and side effects. And you must space the drops. Advise them to wait 5 to 10 minutes between different eyes before dropping the medications. Another thing you must also tell the patient is to avoid increased intraocular pressure. That is by positioning. Keep the head of the bed elevated at 30 to 45 degrees to promote venous drainage from the head. And on day-to-day activities, instruct them to avoid coughing, sneezing, straining bowel movements, and bending over from the waist, okay? The clothing that they wear must must be having tight collars or neck. The advice against tight collars and neckties. Okay. And for their safety cases, environmental adaptations must be must be of essence, because you must remove tripping hazards like throw rugs. So hizo marags za nyumbani asikuwe nazo to accommodate the loss of peripheral vision. Now, they must have no mydriatrics. Mydriatrics, by that I mean, you ensure that the client never receives pupil dilating medications like atropine, as they may cause acute angular closure glaucoma. Okay? So, as a nurse, you have a lot to do with patients with open angle glaucoma. So, shall we proceed to the next question? The one that is an emergency is closed angle glaucoma. So we are moving to 364. Melena can be caused by small bowel obstruction, abdominal aortic aneurysm, internal hemorrhoids. B, perforated gastric ulcers, neoplasms in the transverse colon. C, bleeding esophageal varices, perforated gastric ulcer. D, abdominal aortic aneurysm, splenic neoplasm, esophageal varices. Can we try this? First of all, you must know what melena is. I can see we are going with C. C. So melena is the passage of black tarry stool and is a sign of internal bleeding from the upper digestive tract. When you have lower digestive tract bleeding, it's reddish and bloody. So bleeding of esophageal varices and perforated gastric ulcers are major causes, because when there are swollen veins in esophageal varices in the food pipe, this causes high blood pressure in the liver blood vessels. And if they break, they bleed heavily into the stomach. When there's a perforation due to gastric ulcers, those deep holes in the stomach lining cause damages to the nearby blood vessels, and they bleed. So both conditions can cause large amounts of blood to enter the gut. Okay. And when that happens, one thing that happens is the digestive acids and bacteria break down this blood, and this makes the stool black and tarry. So other options that we are looking at are likely to cause bright red bloody stool instead. Okay. So you see, when there's this bleeding esophageal varices, it is caused by severely enlarged and dilated veins in the lower part of the esophagus. And they bleed because they develop portal hypertension. That is high blood pressure in the liver's portal vein system, which is commonly caused by liver cirrhosis. So make sure you reduce your drinking. The intense pressure makes the thin-walled veins that are fragile. Those veins are always very fragile, and they lead to spontaneous rupture. So when there's massive amounts of blood that are swallowed or passed directly into the stomach, where the gastric acid degrades the blood before it travels through the intestines, you get black tarry stool. When there is gastric ulcers, those deep sores break the inner lining of the stomach. And once it is eroded, there is completely thorough, they erode the walls thoroughly and the tissue layers. So that ulceration process eats away the mucosal defense layers that eventually expose and tear the nearby blood vessels, like the gastric arteries. So that pooling of blood is immediately exposed to highly acid gastric juices, the HCl. that ensures rapid conversion into dark hematine that characterizes the melena. So the melena is caused by hematine, okay? So the others will cause tarry stools. Now, can we see? Oh, hematochezia. Now, hematochezia occurs from, you see, you had asked, Sharon has talked about hematochezia here, and hematochezia or maroon stool occurs because there is a transverse colon neoplasm. The lower gastrointestine or the large intestines are bleeding, so you get hematochezia or maroon stool, okay? So let's move to the next question. So just try to remember that melena, we have esophageal varices, gastric ulcers, transverse colon neoplasm will cause hematochezia, internal hemorrhoids like lower GI or anal canal will cause bright red stool, just like in hemorrhoids, okay? So let's see the next question, 365. Which sign and symptom should a nurse expect to find in a client diagnosed with ulcerative colitis? A, 20 bloody stools a day. B, chronic constipation. C, oral temperature of 39 degrees Celsius. D, hard rigid abdomen. Let's give it a try. Can see most of us are going with A. A. Why A? You see, 20 bloody stools a day is a difference because the inflamed colon not properly absorb water, and that causes frequent bleeding. And the client's classic bloody diarrhea is eminent. During acute severe exacerbations of the disease, you'll expect that the client passes 10 to 20 bloody stools in a day, okay? For chronic constipation, ulcerative colitis primarily triggers frequent urgent diarrhea rather than constipation. While mild inflammation isolated strictly to the rectum, ulcerative proctitis, inflammation of the rectum, that can occasionally cause localized constipation. Chronic constipation is not a characteristic finding for such in ulcerative colitis. Now, temperatures exceed of 39 degrees. You see, an oral temperature of 39 degrees indicates high fever, while a low-grade fever can accompany inflammatory flare-ups. A sharp spike to 39 is quite unexpected. So acute finding that usually signals an advanced secondary complication such as systemic infection, or there could be a perforation, or there could be a toxic megacolon in such circumstances. If a patient has a hard rigid abdomen, as in choice D, that is a classical sign of peritonitis. The peritoneal cavity is inflamed, and that is life-threatening because it results from intestinal imperforation or perforation. It is not a standard expected clinical finding or manifestation in ulcerative colitis. So during an acute flare-up of the ulcerative colitis, the primary nursing goals are to restore hemodynamic stability. So as a nurse, you make sure that there's an IV access to initiate aggressive fluid resuscitation. And typically, you give isotonic crystalloids like normosaline or Ringer's lactate to combat dehydration from severe diarrhea. You also have to monitor electrolytes, especially you track potassium, magnesium, and calcium closely, because severe diarrhea causes rapid potassium loss, increasing the risk of cardiac dysrhythmias. Okay. You also have to make sure that you strictly observe internal input and output track, because documenting the exact frequency, volume, and consistency of the stool, you must also check all the stools for gross blood because of cases of hematochezia, okay? You must also, as a nurse, make sure that you maintain nil per oral or low residue status. By this, when the patient is NPO or an unrestricted clear fluid diet, liquid diet, it initially rests the inflamed bowel. Most of them always also go for parenteral nutrition, because if the patient remains nil per oral for more than a few days, collaborate with the provider to initiate total parenteral nutrition, TPN, to prevent severe malnutrition. And then you also have to advance the diet carefully. When the flare subsides, transition the patient to low residue, low fiber, high caloric, high protein food. Remember, low fiber, high caloric, high protein diet. This triggers like dairy. Avoid triggers like dairy foods, things like caffeine. I wonder if somebody will take alcohol under such circumstances, and highly seasoned foods. Spicy foods will exacerbate the condition. Also, as a nurse, you administer the scheduled corticosteroids. So you give ordered IV corticosteroids. In most cases, they give methylprednisolone to rapidly reduce systemic bowel inflammation. You also have to give antidiarrheals. Do not administer oral antidiarrheals agents like loperamide or diphenolxylate or atropine during an acute severe flare. These medications decrease bowel motility and can trigger a fatal complication called toxic megacolon. Okay? You provide pain relief, especially antispasmodics and analgesics. But which pain relief will you want to avoid? Which group of pain reliefs would you want to avoid? Hapa kuna kusikia tu, lazima this is an exchange program. You avoid NSAIDs because things like ibuprofen, they can cause gastric irritation and worsen the ulcerative colitis flare-ups. And then you monitor for complications. So you must always assess for toxic megacolon. Check the abdomen at least every 4 hours for sudden abdominal distension, severe tenderness. What else? Bowel sounds. You have to check for loss of bowel sounds. You also have to check for high fever, because that would mean there is a toxic megacolon, and tachycardia because potassium has been lost. Okay. You also monitor for bowel perforation. Things like peritonitis, including a rigid, broad-like abdomen. And then when they claim of sudden excruciating pain and rebound tenderness. You also track for hemoglobin and hematocrit, because monitoring these serial CBCs, severe mucosal bleeding can lead to acute anemia that will require transfusion, okay? Another thing a nurse should do is to make sure that the perineal skin integrity is taken care of. So you cleanse the perineal area gently after every stool using alcohol-free moist wipes, or a bidet rather than a harsh toilet paper. And you apply barrier ointments. Apply zinc oxide or or petroleum-based barrier creams to prevent skin breakdown. There is always skin breakdown, there's always excoriation and infection from frequent acidic stools, okay? So always, you see, in ICU, most of these cases you find in these developed countries, and that is when you realize nursing is hard. Cities, and give me the next question. Thank you, Joy, for the evidence. Thank you, Shaz. So those who want to go abroad, read and read. Otherwise utapelekwa sluice, uambiwe ukuwe sluice nurse. Next question, 366. Early miscarriage refers to loss of pregnancy spontaneously in between 16 to 24 weeks, spontaneous loss of pregnancy from 16 to 30 weeks gestation. C, spontaneous loss of pregnancy from 0 to 16 weeks of gestation. D, loss of pregnancy between 24 to 30 weeks. So it's a case of timelines. Can we try that? Early miscarriage. Early miscarriage. When do we have early miscarriage? Can see A, C, 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 A, C, A, C. Oh, now I'm going to be forced to go through all the choices. Okay. An early miscarriage is defined as the natural loss of pregnancy before the 12th to 16th week of gestation. So we go with C. So most medical guidelines define miscarriages happening between 0 to 12 weeks as early, while losses between 12 and 20 to 24 weeks are considered late miscarriages. Okay. So the common causes are always chromosomal abnormalities, because research has it that over 50% of early losses happen due to random genetic errors during fertilization. And there can also be maternal health conditions like uncontrolled diabetes, severe thyroid disease, or blood clotting disorders. We can also have uterine or cervical issues where fibroids or abnormally shaped wombs expel the fetus. And also lifestyle, advanced maternal age, over 35 years of age. So kama mnazaa, tafadhali jaribuni mapema. Heavy smoking or drug use. The clinical context is that most early miscarriages are completely outside a patient's control. So mtu asikublame ati umetoa mtoto or something. Now, routine exercises, working, and sexual intercourse do not cause miscarriages as people always think. You see, the warning signs to early miscarriage would be vaginal bleeding, which ranges from light spotting to heavy bleeding with clots. There could be abdominal pain, severe cramping, or lower back aches. And tissue passage, fluid or tissue passing from the vagina. And then loss of symptoms, sudden disappearance of morning sickness or breast tenderness. And you find that the clinical context is that light spotting is common in early pregnancy and does not always mean a miscarriage will happen. But heavy bleeding or severe localized pain requires immediate medical evaluation to rule out an ectopic pregnancy. And we manage this medically. For expectant management, you waiting for the tissue to pass naturally up to 80% recorded effective within 14 days. Using medications like misoprostol to help the body empty the uterus. Others can undergo surgical processes like uterine aspiration or curettage to safely remove the remaining tissue. And the treatment choice depends mostly on patient's preference and medical stability. If the patient is rhesus negative, an injection of Rogam D is required to protect future pregnancies. Because you see, once you start losing pregnancies, it normally recurs. And for this woman to recover, they need physical rest. So they avoid strenuous activity for a few days. They must have infection prevention, avoid use of tampons, avoid douching or vaginal intercourse for 1 to 2 weeks. I know that will affect various men. And then contraception can be used, like hormonal birth control can be started immediately if desired. And then you also give them emotional support. Counseling and support groups for grief management, you see. So physical recovery usually takes a few days to a couple weeks. And but emotional recovery can take much longer. Ovulation can return as early as 2 weeks after an early miscarriage. Okay. There are also evidences here by morphine. Early miscarriage, a loss of pregnancy in the first 12 weeks of gestation. Chemical miscarriage is used before 5 weeks of gestation. Late miscarriage, a loss of pregnancy after 12 weeks but before 24 weeks of gestation. Threatened miscarriage, ongoing pregnancy with the presence of vaginal bleeding indicating possibility of miscarriage. Complete miscarriage, a loss of pregnancy where all pregnancy tissues have been left in the uterus. Incomplete miscarriage, a loss of pregnancy where some of the pregnancy tissues remain in the uterus. Missed miscarriage, also known as delayed or silent miscarriage, a loss of pregnancy where the embryo of the fetus has died without associated bleeding or pain, and the embryo of the fetus has stayed in the uterus. Inevitable miscarriage is where bleeding has commenced and cervical os is open, but the pregnancy tissues remain in utero. The pregnancy will proceed on to an incomplete or complete miscarriage. Recurrent miscarriage, the loss of 3 or more consecutive pregnancies before 24 weeks. Miscarriages are only further investigated after a woman has experienced a recurrent miscarriage. That's why we were being told that treatment choice depends mostly on their preferences, because if a patient is rhesus negative, an injection of Rogam is required to protect future pregnancies. Okay. Thank you. Samuel pia alituma kitu hapa, spontaneous miscarriage. The term miscarriage is used to describe a spontaneous pregnancy loss in preference to the term of abortion, which is associated with the deliberate ending of a pregnancy. A miscarriage is seen as a loss of the products of conception prior to completion of 24 weeks of gestation, with an early pregnancy loss being one that occurs before the 12th completed week of pregnancy. Thank you. Abortion na miscarriage. We all know. Abortion and miscarriage. One is spontaneous, one is deliberate. Choose you. Give me cities. Time is of essence. The timelines are almost the same, with 12 weeks being the standard cutoff. Yeah, so 0 to 12, but most literature says 0 to 16 early. But between 12 to 24, yeah, so there is an interlap. Next question, please. Thank you. The patient was brought to the outpatient department with a cut wound. Which is the most appropriate intervention for the triage nurse? A, wash the site with soap and water. Ish. B, squeeze the site to enhance bleeding. C, apply a tourniquet proximal to the site. D, apply a tourniquet distal to the site. How do we proceed? Jaribu. Utaosha na sabuni. Yeah, I can see most of us going with C. You apply a tourniquet proximal to the site of bleeding. Why would you do that? You apply a tourniquet proximal to the bleeding site so that more blood is not lost. Okay. As care is done for that area that was, to arrest the bleeding so that hapana, early abortion is early miscarriage. Don't you think abortion and miscarriage go hand in hand? It depends on how you want to look at it. But just know that abortion is an intentional end of a viable pregnancy through medication or a medical procedure, whereas a miscarriage, also called spontaneous abortion, is the natural loss of a pregnancy. So we were talking about this patient who has come to the outpatient department with bleeding. So you apply tourniquet proximal to the site to arrest the bleeding as care is done to the part that was affected. Can I get CTs? Hii miscarriage na abortion imewasumbua sana. Morphine, you'll have to chime in later on to say something about this. Because watu wa abortion na watu wa miscarriage wako na shida sana hapa. Or better yet, let's do this. Let me take you back. An abortion intentionally ends a viable pregnancy through medication or medical procedures, whereas miscarriage, also called spontaneous abortion, it's called spontaneous abortion because it's a natural loss of pregnancy. Okay, so don't forget that. Okay, and for miscarriages, there are always chromosomal abnormalities There are always maternal health conditions. There are always uterine or cervical issues. There are infections. There are lifestyle factors like smoking and alcohol taking. Okay. So let's understand that miscarriage is natural. Abortion is intentional. Okay. And abortion can also be intentional because of maternal health conditions. But how would you know you have maternal health conditions if you've not gone to the hospital and ascertained that? So that will still be, that will be an abortion. But miscarriage is unintentional. It just occurs without your, we hukuwa unajua, but it has occurred. But for abortion is something you deliberately decide. Okay. Morphine says here that abortion, the expulsion of the fetus from the uterus before it has reached the stage of viability, that's the 20 weeks of gestation. An abortion that occurs without intervention is known as a miscarriage or spontaneous abortion. When deliberate steps are taken to end pregnancy, it's called induced abortion, or less frequently, induced miscarriage. The unmodified word abortion generally refers to an induced abortion. Abortion is the process of partial or complete separation of the products of conception from the uterus wall, with or without partial or complete expulsion of the uterine activity before the age of viability. The age of viability is 28 weeks as per India. A miscarriage is the spontaneous loss of a fetus before the 20th week of pregnancy. Pregnancy losses after 20th week are called stillbirths. Miscarriage is a natural. So abortions could be threatened, inevitable, or incomplete. Complete, missed, or septic. Now, when it's threatened, the viable pregnancy, the viable pregnancy but bleeding, the clinical features are mild bleeding, breast, progesterone, and you monitor. In the event of inevitable abortion, abortion occurs, abortion process has begun and cannot stop. Features are moderate heavy bleeding, moderate severe pain, the cervix is open, the uterus conceptus partly displaced. Okay, there's clear flow partially displaced. Okay, management is to monitor, prepare for evacuation. Incomplete is partial expulsion of products of conception. Heavy continuous bleeding, severe cramps, tissue passage, the cervix is still open, the uterus products are retained. Admit, monitor vital signs, surgical evacuation, manual MV, and then direct and curettage. And then you give anti-D. The complications will be infection, medical treatment, and anti-O. Complete is all products of conception have been expelled. And the key clinical features are bleeding, decreased, bleeding is decreasing, pain is resolved, cervix is closed, uterus is empty. So it requires no observation or specific treatment. Missed abortion is when the fetus is dead but retained in the uterus. Features are none or dark spotting, no pain, no fetal heart movements, and heart rate. The cervix is closed, dead conceptus is retained. This is when we always have this, what kind of delivery? Septic abortion, superimposed infection, foul discharge, severe abdominal pain, fever, chills, tachycardia might be open, the cervix might be open, uterus might be infected. So admit, give antibiotics, evacuate, and fluid replacement. So be it threatened, inevitable, or incomplete, bleeding is key, and pain. Incomplete, there's decreasing, and empty. Incomplete, there's severe and resolved. In septic, there's infected and infected. So you give anti-O for incomplete, clear blood in inevitable, and bleeding. So abortion inasumbua. Abortion inasumbua. Yeah, so go through the threatened types, the inevitable, incomplete, complete, and missed abortion, and try and give it an understanding. Give me the next question. (368). It says, bacterial growth phase where cellular division seems to have stopped or ceases for a period of time is called A, lag phase, B, log phase, C, stationary phase, D, death phase. Can see A, can see A. C. More responses tuko wengi. C. More responses. So in the life process of a bacteria, while it is being infective within the body system, TK, number your work. I would say, because I'm seeing a variation of answers, so I'll just go through all of them. The lag phase is when the bacteria are first introduced to a new environment, like into your body, and then they do not immediately reproduce. During this initial period, cellular division ceases or seems to have stopped completely, while the individual cells grow in size, okay? And they remain metabolically active and synthesize the enzymes that they require, their RNA and the proteins needed for future replication. In the log phase, this is a period of maximum and rapid cell division. The cells reproduce exponentially. And they do this through binary fusion, meaning the population growth is at its peak rather than stopped. Now, those who are going with C, the stationary phase, while the net population growth stabilizes here, cellular division has not actually stopped. Instead, these bacterial cells continue to divide, but the rate of the new cell production is exactly balanced by the rate of cell death. So due to the depletion of nutrients and the buildup of toxins. And then the death phase is the final stage where nutrients are completely exhausted and toxic waste is high. So the rate of cell death greatly outnumbers any minimal division, cell division, or replication that leads to a steep exponential decline in total living population. So you must realize that phase when the cellular division seems to have stopped is the lag phase, because this is where the bacteria is first introduced to a new environment. They do not immediately reproduce. So it is an initial period. So cellular division is ceased or seems to have stopped completely, while the individual cells are growing, but they remain metabolically active, okay? Actually, this is the graph I was looking for. The lag phase is the metabolic activity where there is no cell division. In the log phase, exponential growth and division, things like beta-lactam antibiotics work during log phase, for example, penicillin. Stationary phase, the proliferation and cell death is in a steady state, and in the death phase, there's declining population. So we go with the lag phase. Unless somebody has a different answer and you give me your evidence. This one is taught in Microbiology 101. Yes, Missy says lag, gathering energy, log, rapid multiplication, stationary growth reduces as there's depletion of resources, death phase, they die. Thank you. There's also that by Geoplots, so you can read through. Give me cities. Oh, lag phase. Lag phase is whereby the bacteria first is introduced to a new environment. So they do not immediately reproduce. But this initial period, there is cellular division that ceases or seems to have stopped completely. While the individual cells grow in size, they remain metabolically active and they synthesize enzymes, RNA, and proteins needed for future replication. And these are cases whereby somebody can become infective. Okay. So let's see and get the next question. We are time bad. You doubt it anyway. T. Look at it like the development of a baby. The lag phase, they're in there. There's replication, RNA is taking place and all. Then the log phase, then they start growing. Nutrients zikifika point zenye imekuwa sana, their death is by expulsion from the uterus. Nitakuconvince kando. Next question. Thank you. A nurse is showing a patient how to use crutches at home and instructing his mother about how to change his bandages. At this time, the nurse is primarily acting as A, patient advocate, B, patient manager, C, teacher, D, decision maker. Tuanguke na hiyo. Yes, under such circumstances, you're a teacher because you are providing education, you are passing on knowledge, and you are demonstrating specific skills like crutch walking and wound care to the patient and the family. So the primary goal of the teaching role is to actually help patients and caregivers to develop the skills and the understanding that is necessary to manage their health independently at home. Okay. At this point, you are not a patient advocate because advocacy involves defending or protecting the patient's rights, preferences, and safety. You are not a manager of care at this point because you are not supervising or coordinating anything or directing a multidisciplinary team. You are not making decisions in this case. This role is to empower the patient and the family to make informed choices rather than making the choices on their behalf. So let's see. Time inasonga. Next question. Thank you. While caring for a patient with a diagnosis of emphysema, the healthcare provider instructs the patient on positioning while assist the patient's ability to breathe. That will assist the patient's ability to breathe when experiencing dyspnea. Which of the following positions will the healthcare provider instruct the patient about? Lie supine while your feet on the blanket roll, with your feet on the blanket roll. Sit upright and lean forward on supportive surface. Sit in a recliner chair at 120-degree angle. Assume a side-lying position. To Peter and I. This one we have talked about so many times. Yeah, I can see most of us going with B. B. Can give me B as UCT. You see, leaning forward while sitting upright, what we call the tripod position or orthopnic position, is highly effective for patients with emphysema and chronic obstructive pulmonary disease experiencing dyspnea. What this posture does is that it maximizes thoracic expansion and it lowers diaphragmatic pressure. And it also allows the accessory muscles of respiration to be used more efficiently. And this reduces the overall working of breathing. When you tell a patient to lie supine, you force the abdominal organs upwards against the diaphragm. So this will significantly restrict movement of the chest wall, okay? If they recline at 120 degrees, this prevents full diaphragmatic excursion. So this position forces the patient to work harder to pull air into the hyperinflated lungs. If they're in a side-lying position, this does not allow the work of the gravity assistance or stability required to utilize accessory chest muscles effectively, which is supposed to be relieving the acute breathlessness. Okay, so give me the next question, 371. So always remember tripod position or orthopnic position. Now, during chest auscultation of a patient, which finding will indicate that the patient has cardiac conditions and cannot be felt in a normal person? A, S1, S3 murmurs. B, S1, S2 negative murmurs. C, S3, S4 murmurs. D, S3, S1, S2. To Peter na hiyo. Can see people going with C, S3, S4 murmurs. S3, S4 murmurs. Yeah, so a normal heart has only two sounds, S1 and S2. Murmurs are abnormal, harsh sounds that are caused by the rushing of blood. S3 and S4 are extra sounds. S3 and S4 combined with murmurs indicate heart problems, okay? So in understanding the S1 to S4 heart sounds, S1 goes something like lab. This is a normal sound caused by the enclosure of the mitral and tricuspid valves. And that happens at the start of ventricular systole. It is best heard at the apex of the heart. S2, dub. So you always hear lab dub. So dub, this is the normal sound caused by the closure of the aortic and pulmonic valves at the start of the ventricular diastole. It is best heard at the base of the heart. Okay. S3, which is a ventricular gallop, it occurs early in the diastolic. It occurs early in diastole during rapid ventricular filling, and it normally sounds like a faint, low-pitched lab dub ta. Okay, you see, you've heard lab dub, that is normal, lab dub. Then you hear lab dub ta, resembling the cadence of the word Kentucky. Okay. And S4 is atrial gallop. So you see S3 ventricular gallop, lab dapta, S4 atrial gallop, and this occurs in late diastole just before S1 because the atria contracting into a stiff ventricle. It sounds like a low-pitched ta lab dab, resembling the cadence of the word Tennessee. So Tennessee and Kentucky are always used to represent S3 and S4. So while S3 can occasionally be benign in healthy children, pregnant women, and trained athletes, a new or prominent S3 or S4 in an adult almost points to a structural heart defect. Okay. Now, when we have things like S3, this ventricular gallop, that means that there is excessive volume of blood rushing into the already overcompliant dilated ventricular chamber. Excessive blood volume or blood rushing into an already overcompliant dilated ventricular chamber. And this could be the causes of diseases like congestive heart failure, severe mitral or tricuspid regurgitation, and dilated cardiomyopathy. For S4, the atria forcing blood into a stiff, non-compliant ventricular wall that resists filling would mean chronic hypertension or high blood pressure or aortic stenosis. It can also mean hypertrophic cardiomyopathy and active myocardial ischemia or heart attack. Okay. If we had time, I would have told you how to use a stethoscope to find these sounds. Because of time, let's just CT. I can see Sharona centers types of heart sounds: S1 lab, S2 dab, S3 ventricular gallop, S4 atrial gallop. So S1, closure of mitral and tricuspid valves, occurs at the beginning of systole, loudest at the apex, good. S2 dab, closure of aortic and pulmonic valves, occurs at the end of systole, start of diastole, base at the base of the heart. S3 causes rapid ventricular filling had in the early diastole, may indicate heart failure. S4 atrial contraction against stiff ventricle occurs in late diastole, seen in hypertensive or left ventricular hypertrophy. So if you were in a clinical area, I would have showed you how to use the stethoscope to find these sounds. Give me CTs. And the next question, 372. How does time move, guy? CTs. Hizi CTs ni kidogo bana. Ama mmechoka? Content imekuwa mingi. Nasley, caring for a client with pneumothorax and who has had a chest tube insertion, notes continuous gentle bubbling in the suction control chamber. What action is appropriate? Nasley, caring for a client with pneumothorax and who has had a chest tube inserted, notes continuous gentle bubbling in the suction control chamber. What action is appropriate? A, do nothing because this is an unexpected finding. B, immediately clamp the chest tube and notify the physician. C, check for an air leak because the bubbling should be intermittent. D, increase the suction pressure so that the bubbling becomes vigorous. Shall we try 372? And C, C, B, C, B, C, B. Mm-hmm. Thank you. So you must realize that in such a situation, you do nothing because this is an expected finding. Continuous gentle bubbling in the suction control chamber is normal. It tells the nurse that the suction is working. Now, let me tell you some quick facts about these chest tube chambers. The suction control chamber needs continuous gentle bubbling. The water seal chamber needs tidling. That is, water should be moving up and down with breathing. Air leaks, continuous bubbling in the water seal chamber shows an air leak. Clamping, do not clamp chest tubes unless looking for a leak. Clamping can cause a collapsed lung. Okay? So you do nothing because this is an expected finding. If there's continuous air leakage, then you can clamp so that you try to find out where the leakage is coming from. Though clamping is not is never advised because it can lead to a collapsed lung. I worked in ICU for long and labor ward na emergency department. But I can write down the notes for these questions and send you in the next 2 or 3 hours. I can send it to you as a PDF or as a Word document. Okay? Give me 373. I will, I promise. Give me 373. Oh, CT is bad. Oh, time is up. Oh, time is up. Okay. Time is up. Time is up. Thank you guys for your good job. Thank you so much. Thank you so much. I appreciate those who worked with the score sheet. I appreciate those who sent the questions, those who answered the questions, and for waking up just for this. So may God bless you so much. If somebody has something to say, please, this is your opportunity. Say something. If you have a complaint, compliment, compromise, say something. You can unmute. Nilishakwambia number 368 I'm going to explain vizuri hadi uelewe. Yeah, or you can unmute and sema ikutoke. Nobody has something to say. Take a look at that graphical presentation yenye Morphine alikuwa ametuma, and then I can explain it to you using that graph. Yeah, that one. Now, you see, you are thinking of this as a, how would I put it, like a disease that is already occurring. But this is the development of bacteria, you see. It is not the bacteria inside the human body. So what happens in the lag phase? When that bacteria is in a new environment, they do not immediately reproduce. You see, during this initial period, there is cellular division that stops completely, while the individual cells grow in size. In that, they remain metabolically active to synthesize the enzymes they require for disease formation. They develop their RNAs and they develop their coating proteins that are needed for future replication. Okay? Now, where they start growing is the log phase. And this is the period of maximum and rapid cell division, where the cells reproduce exponentially through binary fusion. And the population growth is at its peak rather than stopped. Now, when they get to the stationary phase, while the net population in the stationary phase has stabilized, the cellular division has not actually stopped. You see? Instead, the cells are continuing to divide. But the rate of the new cell production is exactly balanced by the rate of cell death, in that they are trying to create a maximum number of cells because of the deficiency in the amount of nutrients and metabolic activity that is required to cause disease. And this is exactly balanced by the rate of cell death due to nutrient depletion and toxin buildup. And then after that, they get to the death phase, which is the final stage, whereby the nutrients are completely exhausted and toxic waste is high. So the rate of cell death greatly outnumbers any minimal division. So this leads to a steep, how do I put it? This leads to a steep exponential decline in the total living population. Now, under such circumstances, now, during all these phases, they can cause disease. But this is their developmental process. It is a bacterial growth process. It is not a bacterial infectivity process. Get the difference? That's all I have to say.